Hello and welcome to a new episode of GETECU Podcast, where we will talk about a really hot topic in IBD, in particular about the possibility of preventing the disease, which is currently a real challenge. There are many meetings and opportunity to discuss about IBD, and there are usually topics like epidemiology, medical therapy, surgical techniques, but it was not until very recently that the possibility of preventing the disease was raised. Several factors have influenced into this. For instance, we know now much more details about the risk factors for developing the disease and about other aspects such as the importance of an earlier diagnosis, which is together with increase in the worldwide prevalence of the disease, leads us to consider whether prevention would it be feasible or not, and who would also be the target population to apply these interventions, and even more how this could be achieved. To explore deeper into this topic, we have one of the international leaders who best knows this topic. She is Joana Torres. Joana, welcome. It is a great pleasure to have you here today, and thank you very much for attending our GETECU meeting and this podcast.
Thank you so much, Iago. It's my pleasure to be here, especially to discuss this topic, which is so close to my heart.
And Joana, you are a gastroenterology consultant at Hospital Beatriz Ângelo and Hospital da Luz in Lisbon, but you are also linked to the Lisbon University and the Icahn School of Medicine at Mount Sinai in New York. And we know that you are an international expert on the field, so we have many questions about this topic for you. So let me start with the first question, because we know some data about other immune-mediated diseases. This has been already explored in diabetes, on rheumatoid arthritis. So what can you tell us? What can we extrapolate to IBD about these trials?
So I think that's a very good point, because when I started to work in the topic of prediction and prevention in IBD back when I was at Mount Sinai working with Jean-Fred Colombel, who is the godfather, I think, of IBD and prevention in IBD as well, I was really amazed going through the literature and realizing that type 1 diabetes, rheumatoid arthritis had been working on the possibility of predicting and preventing disease for many years. So, for example, in RA, they started in 1980, where they went to high-risk populations, which were the Pima Indians in Arizona, and they were going there every year, looking at their joints, making x-rays, taking rheumatoid factor, which was the only available serum marker, and they saw that those people with rheumatoid factor were at highest risk for developing RA. And with type 1 diabetes, the most famous study is the TEDdy study, which started, I think, around 2000, 2004. So we kind of see how late we are now arriving in this topic of prediction and prevention. And so I think GEM study was the first that started. This is a prospective study following first-degree relatives of patients with IBD. And so I think it started maybe around 2009, 2010. So it's been going for a while, and we are now seeing the results. And so what we have seen in the other areas of immune-mediated diseases, first, we know that disease processes start many years before diagnosis. And this has been seen in type 1 diabetes, rheumatoid arthritis, Alzheimer's, multiple sclerosis. So essentially, when people get symptoms, disease has started many years before. And sometimes there is already damage, whatever the organ you are discussing, which is irreversible. And so I think this is a plea for us to try to identify disease earlier and to try to intervene earlier. And so this is what our colleagues in other areas have started to make. So they have started many years already also to conduct disease prevention trials, which is, I think, a new terminology to us, right? To conduct a trial where we aim to prevent disease onset or to delay disease onset, or at least to modulate the course of disease. And so very recently we saw some positive trials, for example, with abatacept in RA, where they show that they delay disease onset, also with teplizumab in type 1 diabetes. And I think this really opens a new paradigm for us also in IBD, because we know once disease is diagnosed, it's irreversible. We don't have any cure. And often we need to call our friends, the surgeons, also to intervene. And we still see that many patients live with a huge burden and disability. So I think what we can learn from them, because looking at their literature, of course, they, sometimes did not conduct adequate risk stratification. So even in populations at risk, I think we need to have the appropriate biomarkers to really identify those with the highest risk, so potentially where an intervention can be beneficial. And so I think, we are also now living in a time where we have the possibility to conduct multi-omic studies, high-throughput platforms, and we have access to the serum samples and other samples that can help us to learn what are the disease processes before diagnosis and how we can intervene that in the hope that we stop those processes and prevent disease.
You already mentioned some of my questions because we are thinking, well, we can prevent IBD, and this is not new in other diseases. As you mentioned, it has been already ongoing for a while, but they already selected these probably high-risk populations in type 1 diabetes, in RA. So do we have this target population also in IBD? How can we select the best people for undergoing these trials in IBD?
Yeah, so the obvious population to target for trying to diagnose earlier and to prevent are the first-degree relatives, just because they are the ones with the highest risk for developing disease. So having a family member, a first-degree relative with Crohn's, increases the risk by 8 times for their first-degree relatives to develop disease. Having a first-degree relative with ulcerative colitis increases the risk by approximately 4 times. However, it's still a relatively low risk, right? Most of the first-degree relatives will not develop disease. So just based on family history, I think it's not enough. So I think that starting by those first-degree relatives, then we need to apply other clinical risk factors, which we have learned from epidemiological studies, such as smoking, exposure to antibiotics, other immune-mediated diseases, in other family members as well. And of course, then we need to apply and to develop the biomarkers that can really help us to select those with the highest risk that will benefit from a dedicated intervention. So I think this is the way to go if we plan to use an intervention that it's, for example, a drug to touch upon disease, altered immune pathways. Of course, that, we can also apply safe interventions to first-degree relatives just based on their standard risk. I think it's also possible that we come to a time where we will have a very good biomarker panel and that we will be able to use that biomarker panel in the general population. We don't know, but for example, those steps have been given in Alzheimer, for example. So, there may be a time that we will have so good biomarkers that will help us. But for now, I think it's really the first-degree relatives that are the population that we plan to study.
Well, so let's imagine an ideal world where we have these biomarkers, we can select people, and many patients, they come to the clinic and they ask about diet. How can I modify and do some things like quit smoking or change my diet? So, well, once we have selected this population, what are the interventions that you think are the best with a good safety balance also?
Yeah, so I think it depends on the risk, right? So I think the problem is that we still don't have a good idea of the history of events before disease is diagnosed. And so, in my view, it's possible that once there are many biomarkers, many inflammatory biomarkers circulating, many dysregulated pathways, I think maybe having a safe intervention like diet, I may be wrong, but I think maybe it will not be enough. And maybe, what we will do is really kind of push the needle a little backwards, and we will be able to essentially diagnose disease many years before, and we will be able to intervene with some pharmacological intervention. However, having said that, generally speaking, and I get this question often from first-degree relatives or from parents who have children at risk, based on what we know that a a Mediterranean diet is associated with risk reduction for IBD. We know that avoiding unnecessary antibiotics is associated also with lower risk for IBD. Vaginal delivery, probably, and other early life exposures. So these are all measures that promote health, have no harm. And so, avoiding smoking, for example, in first-degree relatives, I think this is also very important. And so I think we could propose all those measures to everyone in general, but of course to the first-degree relatives in particular. Educating about those risk factors, I think, could already be a step to, lower the overall incidence and burden of disease in those first-degree relatives. And so I think it depends on where they are in their risk, in their trajectory to develop disease. And I don't think we have a good sense, what is the ideal intervention that we can apply at each step before disease is diagnosed.
And there's even a more difficult scenario, which is those children of mothers that have IBD and those early life interventions that we can consider in these babies, because you already show us with very nice studies from the meconium studies and related studies that these children, they already have a high fecal calprotectin, a different microbiota. So is there anything we can suggest in the future, at least, to these babies?
So this is, I think, an excellent question. So you are mentioning the meconium study. This is a study led by Inga Peter, where I've been involved. And the meconium study followed babies born to mothers with Crohn's disease and also ulcerative colitis and from controlled pregnant women. And as you said, we saw that those babies already have different microbiome. They have higher fecal calprotectin as compared to control babies. Of course, they don't have disease, and probably just a few will develop disease. However, I think it shows us that the early life period is probably an important period of life. I think maybe more in Crohn's and ulcerative colitis, maybe I'm wrong, but where disease processes or the risk for disease starts to be modulated. And this is actually across many diseases. It has been shown that this is the period of life where the immune system is educated and where either resistance or susceptibility to disease can be modulated. And so I think promoting a healthy microbiome colonization in babies, it's a potential way to try to lower their risk or to modulate disease risk or increase their resistance to disease. There is a very important study ongoing. I think we will hear the results next year, which is the MELODY study, where taking advantage of the meconium study infrastructure, they are offering an anti-inflammatory diet to pregnant women with Crohn's. And so we will see whether that has an impact in the baby's microbiome and in the baby's calprotectin, for example. We are also conducting a study trying to measure environmental factors using blood spots from babies born to IBD, using baby teeth from babies born to IBD, so it's kind of crazy stuff. But maybe we are able to identify some specific environmental exposures that happen during that susceptibility period or that window of education, which is early life, that may be associated with future risk of disease development. And so if we are able to identify some risk factors or some environmental risk factors, then we can try to, develop measures to avoid those risk factors, and potentially, that will lower the risk of disease. So many things are currently ongoing, hopefully that we will learn from them.
And you're speaking like for the future, but are we going to see all these measures, interventions in the near future? What do you envision about this topic of preventing the disease?
So I do think it's coming closer than later, actually. So many efforts are ongoing. I think it's becoming a very hot topic in IBD. It's attracting a lot of attention, which is good, because then it's also we are finally getting the funding support that we need to run the studies, to study the biomarkers, and to develop the trials. So, those efforts are currently ongoing. And so I think in the near future, we will have, I hope we will have the platform that will help us to recruit people at risk for developing IBD to start to conduct the first disease prevention trials, or disease interception trials. And so to answer very rapidly your question, the solution is to have collaborations, to develop networks, right? And to work in collaboration in Europe, also with USA, Canada. They are really leading the field in developing some of these studies. And, through these collaborative efforts, like it was what happened in type 1 diabetes, having multiple centers recruiting these people, educating people about risk factors, identifying those with the highest risk, and potentially developing the infrastructure to start to recruit these people into prevention trials, I think we will get there. And I hope that, it will help us really to modify disease course, even if we are not fully able to get rid of disease forever, that we will be able to identify disease much earlier, and whatever therapies or dietary strategies or other strategies may help us to change disease course and make what I think it's still a very severe disease a much milder disease and easier to treat and to follow up and to manage over time.
That's amazing to see that you are very optimistic about this intervention.
I'm a very optimistic person, generally speaking.
We're really grateful of this perspective, and we know that there is a lot of data coming out every month about this topic. So it's great to have you here and to speak about this topic with you, which is a great pleasure.
Thank you very much, Iago. Thank you.
And to our listeners, I hope you enjoyed this interview, and I strongly advise you to check for future research by Joana and his team. As always, you are all invited to join us again for future GETECU Podcast.